Hi, my name is Dr. Chantal Thomas, and I'm part of the behavioral health team here at Access Community Healthcare Center. And I'm going to be talking to you as medical providers today about the pitch that you use when you talk to patients about pain. So, one of the things that we may want to emphasize at the very outset in terms of discussing pain management strategies with patients is that there are many myths out there about pain management and about pain itself. And part of your job as a medical provider is to unfortunately work against some of the misinformation that patients have received along the way. It's also to make clear to patients who are dealing with chronic pain conditions that many of the tools that we have in terms of the biomedical approach are not really all that effective. And that can be disappointing, certainly for patients and also for providers, but it's important for us to put out there at the very outset that quite honestly, surgery or narcotics or opiates are not necessarily a great management strategy for lots of patients for various reasons and because they really don't work that well for a certain subset of the population in terms of pain management. Part of the reason why I'm having this discussion is because I realize that for lots of patients who are being prescribed narcotics, that most of the time that you spend with a patient in terms of your office visit time is focused on discussion about narcotics, which doesn't allow you a lot of opportunities to shift the focus onto things that are more important in the long run in terms of quality of life, and that is focusing on the patient's function and not necessarily just on their subjective pain rating. It is important to emphasize at the outset that pain is not just about a signal in your body, but it's a complex experience that the patient goes through that involves physical, emotional, and cognitive sensations. And as a result of that, we don't just purely approach pain from a perspective where we just manage the physical sensation through the use of a pill or through the use of surgery, but rather that we need to consider that there are other interventions that address the emotional aspects of the pain experience, the psychological and the cognitive aspects of what it means to be dealing with the pain condition. So, some of the most common pain myths that are out there that can cause quite a bit of frustration and difficulties in terms of getting a pain condition under control is the fact that many people experience pain as a sign of something dangerous or harmful, and as a result, they engage in what would be considered pain avoidance behaviors. Well, of course, pain is something that's unpleasant for all of us, and we're taught from a very early age that if you feel pain, something dangerous is happening. This can be very confusing for patients who have a long-term pain condition because, as you know, they're experiencing pain on a daily basis, and if they are fearful of any activity that causes pain or fearful of the pain sensations themselves, it would really limit the amount of things that they can do. It would really limit the activities, and it would also limit the types of therapies that they might be open to. So it's very important for us to clarify with patients at the outset that not all pain signals, when it comes to chronic pain, are a sign of harm or danger. And part of our job is really helping patients differentiate between the types of pain that are dangerous and the types of pain that are just a sign of your body working through an area of maybe muscle tension. The difference between pain that happens when you are actually at risk for hurting yourself and the pain that might come, for instance, after a good workout that you might undergo. We used to believe that rest and doing less was the best way to treat pain, and that is a myth that is out there, unfortunately, and has been disseminated for years. And in the common culture, you'll have a lot of patients, family members, or people that they come into contact with talking about using their pain as a guide. So when they experience any sort of pain, to stop doing whatever they're doing and just rest or become immobile. We know that for many conditions, not having regular activities or movement will often make your pain worse. So, in fact, when people have been trying to take care of their bodies and trying to decrease their chance of feeling pain, they have in fact been making a lot of their pain conditions worse, particularly when it comes to muscles or muscle pain, myofascial pain, or muscle tension. Not moving for hours can make your pain worse, make you feel more stiff, and decrease your ability to function. And that can be quite counterintuitive counterintuitive for a lot of patients who are used to dealing with pain by basically becoming immobile. I like this analogy that I use with patients, which is basically we could learn something from the sharks because with sharks, if they become immobile, it actually places them at risk for dying. They need to move in order to be alive. So I try to emphasize with patients all the time that literally just the act of being immobile or being sedentary or not moving for hours or days at a time is incredibly harmful for you, regardless of what weight you are. It puts you at higher risk for both heart disease and type 2 diabetes. And inactivity itself, just not moving, can create a number of different physical complications that can then contribute to more chronic disease states. So I think that's a very important thing for you to emphasize as a provider is that movement is essential regardless of what type of condition your patient is dealing with. The key comes in what type of movement, how much you're doing it, learning how to set limits, and rest is still important. It's just that we don't want people to be immobile for long periods of time. Inactivity can be particularly painful for patients and harmful, in fact, depending on the type of pain problem that you have. And it's important to emphasize that pain can come from different places in your body, that it can come from joints, that it can come from muscles, it can come from nerves. And when pain comes from different places, it tends to feel different. So that's something that we want to try and help patients learn is to differentiate the type of pain they're experiencing. In most cases with chronic pain, there's at least some type of myofascial or muscular involvement, even if it is just coming from compensation in terms of the way that a patient is carrying themselves or holding their body because they're having pain in hips or joints, in their back, or in the nerves that are then causing them to either be inactive or wince or tense certain muscle groups for long periods of time. Because we know a lot about what actually helps in terms of treating myofascial pain, and much of myofascial pain can be managed through stretching, graded activity, gentle movement, and avoiding immobilization. The good news is if we can help patients understand that a good portion of their pain is coming from the myofascia, is coming from muscles, we can empower them to be able to make changes in terms of their activity levels that can really lead to a lot of pain relief. I mentioned this before, basically, that our medical tools don't work that well. And so it's very important for us to highlight with patients that for a long time we've just relied on medication and surgery as the intervention to make things better for patients who are dealing with pain. But we are learning more about that. We're understanding that those are not a way to eliminate pain. And unfortunately, we cannot completely eliminate pain for lots of patients, and that's a difficult thing to come to terms with. In fact, some of the efforts that we make in order to get rid of pain altogether through surgery can sometimes make pain worse and cause other problems. I think a lot of patients hold the fantasy that somehow there's a surgical intervention that might just eliminate their pain altogether. And this is also a dangerous type of thinking when it comes to the patient's perspective in terms of narcotic management. If their goal is to not feel pain altogether, then you've got another issue in terms of managing or dealing with that pain patient, because their goal is going to be to continue taking medications until they feel no pain at all. It's very important for us to provide education about how narcotics actually work for patients, that they don't actually heal or treat the pain source, rather they just block your ability to feel pain in your brain. What can be even more problematic is that once your body gets used to these medications, they can stop working, or you may need to use higher and higher doses in order for them to have the same effect. This would be the physiological experience of your body developing a tolerance to these medications. What is also concerning is that these medications can result in harmful side effects to you and your body as well. I'd also like to address the fact that when you're managing a patient with narcotics or opiates, much of the time that you spend in an office visit can focus solely on medication management or narcotic management. And this can be very frustrating for both patients and for providers. For a number of reasons, one of which, when the medications that you were prescribing to a patient stop working, patients intuitively just want to keep increasing the medications. They think that's the solution and the answer. And this can also be very complicated because some of these medications can cause harm in other ways, and develop other risks such as respiratory compromise, depression. They can interfere with sleep architecture, and if patients are getting worse sleep, then their pain can be much harder to manage as well. For those reasons, providers might feel a sense of conflict or frustration in needing to increase the medication, especially if they're questioning whether or not this is the best management strategy to begin with. Um, so, a lot of the research out there now is raising some questions about what type of patients are most likely to benefit from narcotics, and not just assuming that that's a good intervention for all patients who deal with pain. The other aspect of this that is important to be aware of in terms of the research is that there are some studies that show that over time, with narcotics, as I mentioned before, because your body can develop a tolerance or dependence to it, the overall pain levels that people report, when compared with groups that aren't getting narcotics versus patients who are getting narcotics, if we control for symptom severity, the pain level or the pain rating per the patient doesn't really change over time. So, the other aspect of this is that when patients are being managed on narcotics and they are more disconnected for the sensation of pain that happens in their body because it's getting blocked by the narcotics, they're more susceptible to injuring themselves because they're not aware of what activities actually are harmful. Which can lead to you having an increased risk for hurting yourself in terms of your day-to-day functioning. Because narcotics are more sedating, they can make you more sleepy, less likely to move, cause problems with focus and attention and memory. And for many patients, because they're actually central nervous system depressants, they can worsen depression, all of which can lead you to function more poorly and also have a poorer quality of life. Because narcotics can cause more risk than benefit, we are trying to shift our focus when it comes to managing pain over time to other interventions that have less risks or to medications that are non-narcotic in order to treat pain. Now, these medications work differently in your body because the ones that we're talking about, the non-narcotic medications that we're talking about, don't cause your body to develop a dependence and don't cause your body to become tolerant to the medication. So we don't have to constantly worry about increasing the amount that you're on in order to have the same effect. And the nice benefit of using some of these other non-narcotic medications is many of them can actually improve other things that might be going wrong in terms of sleep, depression, and anxiety at the same time. So they give us an opportunity to treat multiple parts of your condition. We understand as a team that making changes to your medication regimen can be very scary, and we understand this, and our goal is the same as yours, which is basically to improve the quality of your life altogether. And sometimes that means taking risks in doing things differently. Most importantly, it requires us to recognize that what you have been doing and what we have been doing together has not been working that effectively. Even though you might get some temporary relief at moments when you first start a new narcotic or when we first increase it, over time it continues to not be that effective, and you're struggling. You're coming in here asking for changes to your medications, and I with you agree that something needs to happen. Something needs to shift. So, what we would like to do is to shift our focus on your functioning and your quality of life rather than just continuing to try and chase pain signals. Pain is going to be part of your life, unfortunately. I wish I could do something to eliminate that, but I do believe that our efforts might be better served to focus on improving your functioning, what you do day to day, or using your functioning as a better way for us to tell whether or not a medication is effective for you. Um, and we're going to be making decisions about medications that we use based on the things that you're able to do on a day-to-day basis. That also means that we're going to be asking you to try and follow through with more activities, or at least try them. The best thing that we know we can do to improve your quality of life and also your pain is also to allow you to participate in therapies that we know are effective. And some of these therapies may result in increasing certain kinds of pain in your body, but it's not dangerous pain, and it's not the type of pain that we need to be worried about causing you harm. A lot of people have had bad experiences with physical therapy because they go to 1 or 2 sessions and pain gets worse. And that is what everybody would expect to have happen when you first start doing a new activity or you first exercise a part of your body that hasn't been active for a long time. So it's very important for us to have that expectation, know that's the case, and know that's not a sign that it's not effective. Pain is very complex. It's influenced by so many factors in your body, and some of these factors are physical, but some of them are mental and some of them are emotional. So how you feel and think about your pain changes your pain levels and changes the things that you're able to do from day to day. That's why many of the medications that we use that actually are meant to target mood or depression or anxiety and sleep are also the same medications that will affect your pain levels. That's because the chemicals that they target, the neurotransmitters that they target in your brain, are the same ones that help regulate pain. As a result of that, we need to be really smart and aware of treating anxiety and depression, because if we're not addressing those things, it can really make it much harder for us to get your pain under control. Having stress that goes untreated in your body for long periods of time can lead to ramping up pain signals in your body. And emotional distress or depression or anxiety that's not treated can really amplify and magnify the pain that you experience in your body. It's like handing a megaphone to your pain signals. And we do know that the way that you think about your pain and how you feel about your ability to tolerate it, or how you feel when you experience pain, can really change the way your body processes pain. For this reason, we want to make sure that we involve not only me as your medical provider, but we also want to involve the behavioral health team. We want to involve people who can address these other aspects of your overall well-being, that can talk about your psychological well-being, your emotional well-being, because all of that together affects the experience you have of pain and your quality of life. This may also mean that we ask you to meet with a nutritionist or a diabetic educator. Once again, as I mentioned before, following through with physical therapy and other healthcare professionals so that we can explore all the different things that can make a difference in improving your pain. We want to treat all aspects of your health, and we want to ensure that you have a better quality of life in general. And we understand that making changes can be very scary, especially when you're already struggling from day to day. This is exactly why we want to work with you to make these changes that improve your quality of life, changes that will keep you from feeling as though you're just surviving and will allow you to feel like you're thriving. This is not something you can do alone. This is not something we expect you to be able to do alone. And for that reason, we'd like you to work together with people who specialize in strategies that can be effective. Our goal is the same as your goal, and that's improving your quality of life.